you eat after a transplant could be the difference between keeping that organ or losing it. Every year, thousands of people receive the gift of life, a new kidney, a new pancreas, and they walk out of the hospital not fully understanding that what they put on their plate matters as much as the medication in their hands. Stay with us. Welcome to When Food Medicine, the podcast where we explore how what you eat affects how your medication works and how your health truly thrives. Dr. Rene Lukoya, a pharmacist who believes that food and medicine are partners, not competitors in your health journey. Today, we are talking about organ transplantation, the procedures that take someone from dialysis, from insulin dependence, from a life constrained by chronic disease, and we give them a second chance at life. But here's what most people do not understand. The surgery is just the beginning. The real work happens every single day after transplant. In the medications, in the food, in the choices made at the kitchen table. And I have to be honest with you, this introduction is a little different for me today because I actually went to secondary school with today's guest. We grew up in Nigeria together. This man's journey from our classroom to the operating rooms he leads with a kind of pride that is hard to put into words. Sure. It is an honor to introduce Dr. Dolamu Olaitan. Dr. Dolamu is a professor of surgery and neurology at Rush Medical College in Chicago and the director of the Pancreas Transplant program at Rush University Medical Center. Chairs the Pancreas Transplantation Committee for OPTN UNOS, the national body that governs organ transplant policy across the entire United States. His program at Rush has achieved 100% early graft and patient survival consistently. He was among the first in the world to use donor-derived cell-free DNA to detect organ rejection without a biopsy. He travels to Nigeria pro bono to train surgeons, having helped establish a living donor kidney transplant program at the University of Ibadan, University College Hospital in Ibadan. So, Dolamu, my classmate, my brother, welcome to When Food Meets Medicine. This one means a great deal to me.
Thank you very much, Remy. I really appreciate you inviting me to your podcast. And I sincerely, I'm very grateful to be here. And I'm really impressed by what you do, as I mentioned to you earlier on. So thank you very much for what you do to enlighten the community and the patients.
Thank you, Dolamu. It's very encouraging for people like you to want to show up and also give back. It is an honor. As a pharmacist, I know I fill tacrolimus prescriptions every day. I counsel patients on grapefruit. I watch them navigate this incredible complex medical regimen. And I always wonder, does the surgeon fully understand what happens after the patient leaves the operating room? And with you, I already know the answer. But let us get into it. So let's start at the very beginning. Pause through the transplant journey from the moment a patient is told they need a kidney or pancreas transplant. What does evaluation look like? And what is the wait list experience?
Okay, so thank you. That's a very good question because I think it's very, very important for people to understand that transplant is a journey. The surgery is a very, very small part of it. It's a journey. It's almost like the journey of life on its own. Before you have a child, the delivery you can say is equivalent to the surgery. Before delivery, you have to carry the child for 9 months. That's like the waiting list. So because we have a shortage of organs, we have more people waiting for transplant than the number of available organs. So there's a waiting list for every organ. There's a waiting list for kidney transplant. There's a waiting list for pancreas transplant. There's a waiting list for kidney and pancreas transplant. And so there's a waiting list for every organ transplant, liver, heart, lungs. So on the kidney transplant list alone, there are over 100,000 people waiting for transplant. And in the US, we perform maybe about 45,000 transplants a year. So there's always a gap, and the waiting list is getting bigger and bigger every year. And there are people that die on the waiting list, unfortunately. So that's what the waiting list is about. So when someone has end-stage renal disease and they're diabetic, or if they have diabetes that's difficult to control and it's felt that they'll benefit from getting a pancreas transplant alone, they go to a transplant program to be evaluated for transplant. And then when they are cleared and approved for transplant, they go on the waiting list, which is a national waiting list managed by the OPTN, the Organ Procurement Transplantation Network. So that's where the waiting list comes from. And the average waiting period actually varies depending on the organ, and also varies depending on the region or the state where you are. There are 11 regions in the United States. The waiting period for a kidney transplant in Illinois, for example, is about 5 to 7 years. If you move to further north a little bit, it drops down to maybe about 5 years or 3 years. And it also depends on age too. Older recipients on the waiting list tend to wait slightly shorter because they don't need a kidney that's going to last them for 20 years. But the younger recipient on the waiting list will need to wait for an organ that will be a better match with better longevity for the person. So it's a process.
It definitely is very much. I had no idea. The patient that go through emotional and physically before they even reach that operating room. How do they handle that?
So when the patients go on the waiting list, it's very random. For majority, so there are two different types of donors. We have the living donor, we have the deceased donor. Living donor is more expected because when they go on the waiting list, they have a loved ones that want to donate to them. We set a date. Like I met a patient in clinic yesterday, Friday,
Yeah.
and the patient is scheduled for a living donor kidney transplant on the 22nd. And so when that's planned, they're expecting it. So they're more calm, relaxed, they're excited and looking forward to it. Deceased donors, some of them have been on the waiting list for 3 years, 5 years. And suddenly you call them and say, I have a kidney for you. There is more anxiety, is what I've noticed. So if you look at the whole thing, preparation for surgery, the actual surgery, and even how long the kidney or the pancreas lasts, the living donor is better. You know the donor, it's a family member, it's a friend. So it's easier. But the emotional part you asked is definitely better handled than living donor. We have patients that will say no when you invite them for transplant. But after transplant, I tend to equate it to childbirth a lot. After transplant, all those things go away and they are so happy and
Yeah.
appreciative when things are working.
Working for them. Yeah, I can imagine. So, as someone who works with patients from African backgrounds, and you and I both know our community well, do you see differences in how it could be Nigerians, Ghanaian, Caribbean, or broader African diaspora patients, or even African American approach transplantation? Are there cultural beliefs or fears that you have to navigate?
Yes, I think overall it's quite similar. It's just the way we handle it is slightly different. Like in our religion, there's a lot of influence of religion in Africa. Many people from our background, my impression is that they come in I must say they're easier patients. If that's it may not be the right word to use, but they're easier patients to manage. And conscience wise, you really, really have to make sure that you do the best for them, just like I do for every other patient, because they're easier to almost take advantage of because they don't fully comprehend in a lot of cases though, or want to get involved because most of us are used to what the doctor says is final. We put it in the hands of religion, come in and say, okay, it's almost like, doctor, I'm here, do your surgery. I hope it goes well. If it goes well, they're very appreciative and happy. If it doesn't, it's the will of God. You don't get that a lot on the here. People are more involved, they are more engaged. And personally, I actually like it when patients are more involved and engaged rather than you tell them what to do and they're resigned to you or God.
Yeah. Yeah. I think the religious nuance gets completely lost in mainstream medical conversation. And I think it's exactly why, one, representation in surgery and medicine broadly matters so deeply. Can you share a patient story? A moment where maybe someone's life was truly transformed by transplant that captures why you do this work.
So I would say there are several situations. I really like what I do. I enjoy what I do because I got into transplant because I never really wanted to go to medical school, but my parents wanted me to.
Okay, most of us.
So same thing like many people in Nigeria. But when I got into medical school, what really fascinated me, because I think I have an engineering mindset, is the surgical part. So I knew I only wanted to do surgery. But when I got into surgery, the other part of why my parents felt I would be best suited for medicine was they felt I was kind, quiet, and all those things. But so when I got into medicine, that part, there were things that I was yearning for in a way, ability to use my hands, construct things, and also get gratification from it, from when you put something together, when you help someone. So transplant was really what captured all that for me, in that when you do a transplant, it's not like you're dealing with a cancer patient that you know it's temporary in a way. What you do a change in them immediately, and when they do well. So even this morning when I got to work, I look at labs of my recent patients that I recently transplanted. Seeing the creatinine of zero point 0.9 makes me very happy. So I get gratification from it. I'm happy when they do well. So that's why I like transplant. And there is a patient, I think probably when you do liver transplant, that's a whole different world on its
Okay.
own. I trained in liver transplant too. You make the most profound difference because they're knocking on the doors of death when you meet them. Some of them are unconscious and encephalopathic. When you do a liver transplant, they're completely, it's like life and death. Pancreas can be that way too. Kidney can be that way too, but we don't see more frequently. It's more of switching a chronic disease and making a big difference to their quality of life. But there was a patient that captured it really, really well for me a few years ago. Young mother, I think she was in her late 30s at that point. She had gone through a lot of challenging issues. She had liver cancer, which was very unusual, but she had been cured and she was referred to me by one of my colleagues. And the reason she was referred was because she was diabetic, difficult to control, and she was developing secondary complications of diabetes, neuropathy, and all those things. And she was also having seizures, really difficult to control seizures. And then she had gotten to the point that she was having seizure every day. So they had to implant a brain stimulator so that whenever she was having seizure, the brain stimulator would just kick in. And she was already disabled at that point because of it. Very well educated, working. So I really felt for her. So she was referred, we got involved, and we said, look, if you can get the seizure controlled to a point where she would have a decent, near decent quality of life, that we will release her for pancreas transplants. They put in the neuro brain stimulator, and her seizure was relatively okay. She was probably getting seizure. She was still getting it every day, but the stimulator reduced the actual seizure to maybe once a week or once every 2 weeks. And we did a pancreas transplant. About 2 weeks or 3 weeks after a pancreas transplant, the neurostimulator went off once, and her seizure became pretty much controlled, that she didn't have seizure anymore. It's still difficult to put together, but it was almost like we saved her life, and a lot of things improved for her. She was able to go back to work and pretty much live a near normal life. And so I still look back from time to time and look at her labs, and I'm like, wow, this is so good. And there's another patient, African. So the first patient was a Caucasian. That first patient is still doing well as we speak. The second patient, when she came to clinic, type 1 diabetic or maybe type 2, had kidney failure from the diabetes. And when she came to clinic, her vision was already blurred. She had a 5-year-old daughter that helped her to come to clinic to guide her because she had poor vision, but she wasn't completely blind. 2 years after her pancreas transplant, she was walking, her vision improved. So it makes a big difference for these patients. So when I see that, although it sounds selfish, it benefits me because I look at them, it gives me a lot of gratification myself. So I really like it.
Yeah, I don't think it's selfish. It's two beautiful, different stories, but so different and so really gratifying. It's like the gift of life. The quality of life, it like goes from 0 to probably 90. And that's really what this is about. I'm glad that you get something back. Yeah, they seem to get more, but you're getting something back.
Yeah, and that's why I say to my patients too, when they say thank you, it's as if I have 1,000 kidneys. Every time they're very happy. I say, look, thank you for letting me take care of you, because whenever they do well, I benefit from it too.
Yeah, the kind of doctors we all want. That's that. Now let's talk about what keeps that gift alive. What do patients have to do to make sure that the medications they take. So now that the surgery is done, the patient has a new kidney or a new pancreas, and now this is where it gets incredibly complex. This is where the pharmacist becomes one of the most important people on the transplant team. After a transplant, patients are on immunosuppressive medications for life. Tacrolimus, mycophenolate, prednisone, non-negotiable. They have to take it. So, Dolamu, what do you wish every transplant patient understood about their immunosuppression regimen before they leave the hospital?
So thank you. That's a very good question, Remy, and it's one of the things that we struggle with. I'll go back to my analogy of comparing transplant with that it's a journey and with looking after a child. So the surgery is a delivery, but after you deliver a child, you just don't say, "Oh, you're gone. I'm left on my own." So you really have to nurture the child. So in this case, after transplant, the patients have to take care of their transplant. So one of the things we try to let them know even before they get the transplant, and the care of transplant patients is like we say in Africa, it takes a village to take care of a child. The care of transplant patients takes a village. We have pharmacists that are highly specialized in transplant care involved. We have dietitians involved. We have nurses, several nurses. Team is, probably between 50 and 100 people that are there to support our patients. So the thing we try to let people understand that is that it's very important to take their medications. Those medications you mentioned, tacrolimus, mycophenolic acid, and the steroid prednisone. It's very, very important they take it daily, and also that it's timed. There are several patients that after they are comfortable with their transplant get too comfortable and start forgetting to take the medications. But the body does not completely accept the kidney or the pancreas. So they have to take the medication lifelong or as long as the organs are working. So we try to stress that and we try to support them after the transplant. So that's something I wish most people knew and that they remember after transplant.
Sure. So, what actually happens to a transplant when a patient stops taking their medications? Walk us through what rejection looks like.
So for kidney or pancreas, they have rejection. There's could be a milder form which we call cellular rejection, or the more aggressive one, which is antibody-mediated rejection. What the medications do is to suppress the immune system to a point, not too much that they start having infection, but to a point where the body does not reject the organ, because the body will always see the organ as foreign to it and try to treat it like it's not its own. So that's what the medication is for. And that's why those medications are tailored to that particular patient to the point where we achieve a level that's appropriate for that patient and the type of organ that they have. That's why we always do cross match before transplant. So that's very important. And it's important that they take it as long as as long as the kidney or the pancreas is working. So if they don't take it, what tends to happen is that they have either of those two rejections. The one that we call the cellular rejection may be a little bit easier to treat, but you really don't want either of them. The second one, antibody-mediated rejection, can be more deleterious to the organ and can be challenging to treat. And several people have actually lost the organ just from rejecting the organ. So things they need to look out for, usually typically pain. In the case of kidney or pancreas, they can get pain over where the kidney or the pancreas is located. Most patients know what part of their body it is, usually in the lower part of the abdomen. And for kidney, they might notice blood in their urine. For pancreas, their blood sugar might go up, or they might have fever, could be an early one of the symptoms that they have.
So quite interesting. I know from the pharmacy side, and I do want to be direct with our listeners, missing doses of tacrolimus is not like forgetting a vitamin. The therapeutic window, like you mentioned, is razor thin. And the difference between a dose that protects the organ and a dose too low to prevent rejection is very, very small. So it's quite important that you take your medication. Tacrolimus is one of the most interactions-prone medications in clinical pharmacy. Grapefruit and Seville oranges found in some West African and Caribbean recipes, and even in British marmalade. It inhibits the enzymes that breaks down tacrolimus. So the drug builds up two toxic levels. Pomegranate does the same. St. John's wort, sold in herbal or health shops everywhere as a natural mood booster, it does the opposite. It accelerates tacrolimus metabolism. So it drops to level below the protective threshold, and it can trigger rejection. For kidney transplant recipients, high potassium foods like bananas, tomatoes, potatoes, and leafy greens can accumulate dangerously when kidney function is reduced. So this is not a diet preference. This is a safety protocol. So Dolamu, how often do you see food-drug interactions maybe causing real clinical problems, and what is the one that catches most families most off guard?
Yeah, that's very good. So we see it quite frequently, but that used to be in the past. And the reason for that is because we educate our patients a lot as part of the transplant process. And also after transplant, we mention to them grapefruit is something that we educate them about a lot. Just like you mentioned, it tends to erratically increase the level of the tacrolimus, which is one of the most important anti-rejection medications that our patients take. So that it's not infrequent, but the one that um, we see that we get caught unawares about herbal medications or herbal supplements. Just like you mentioned, St. John's wort is present in many supplements, and it's not uncommon for it to reduce the level of tacrolimus, and then the patient comes with rejection, and they don't think it matters because it's just a supplement. So what we generally tell our patients is, if you're going to be taking any herbal supplement, please let us know, and we get them to see a pharmacist and dietitian to discuss how it could interact with their medications and things like that. But yes, we do see it. Surprisingly, not as infrequent, but I think with proper education of our patient, we see less and less of it.
So what if they tell you, but I've been taking it my whole life, and why do I have to stop now? Because some be that way.
Right. So one of the things, at times, it's not that they cannot take it, but they need, if it's something that is not dangerous for them or that they've adapted to over the years, hopefully we would have known about it when we are evaluating them for transplant. Although some people are so used to it and they don't consider it important that we later find out after transplant. But as long as it's consistent, we can tailor their immunosuppression to it, but it has to be consistent so that the level of the immunosuppression does not go too high and damage the organ like the kidney, because excessive tacrolimus level can damage the kidney apart from even leading to infection, or too low where it will lead to rejection. So if they are consistent in the taking of it, it may be okay. But in a lot of cases, it may not even be necessary. We see working with transplant patients as a partnership where we make decisions together, and it's an important partnership where transparency is very important, and also where things that our patients may not consider to be important, like this herbal supplement, they need to let us know about it, especially when we're struggling to figure out why things are not the way they should be. As I mentioned about a patient, one of my patients that did intermittent fasting. So some of these medications are affected by the transit time. Fast food is going in the gut. So if a patient is going to be fasting, if you can fast every day or a certain number of hours every day and you do it consistently, it's okay. But if you fast on Monday, you don't eat for a whole day on Monday this week, then next week you eat the entire week, that's going to affect the level of the medication because it's taking longer or shorter to go through through.
That's right. Yeah, I actually you beat me to it because the next question I was going to ask
Oh,
is no, which is okay. One of the questions which answers is one which I'll come to is missed doses. Um, between if they miss a dose, does it make a difference? If there's a food interaction, if there's any story you've seen patient missing doses between keeping the organ and losing it.
yeah, we unfortunately see patients miss doses. A lot of people are very conscious of taking their medications, but the longer you've kept the organ, the more we get relaxed or complacent about it. So they start missing doses. When they are missed doses, it increases the risk of rejection because the level in the body becomes too low. So, but if there are patients that will say, I forgot to take my medication yesterday, it's okay. If there's none of us that's perfect. If you forget just once, just take it as soon as you remember and let us know about it, especially if it becomes more than once. And the reason it's important to let us know about it is there are different ways that we can advise. We can actually have you read because for a lot of our patients, after they get conversant with their medications, understand their medications very well, they transition slowly from seeing several members of the team, dietitian, pharmacist, surgeon, to maybe just following up with a nephrologist in our system, or they transition to a nephrologist back to their primary nephrologist. So if we notice that they are struggling with managing their medication, there's a lot of resources that we can provide for them. And pharmacists can work with them on things. I'm sure you know this. There's several things that you can do, like pill box,
Yeah.
different things. So I'll leave that to you to cover, but there's a lot of ways that they can be helped. But they just need to let us know that they need help. There are things that they're struggling with.
Yeah, and you're quite correct in terms of missed doses are a reality of life for most people. You can miss a dose, and it's just not just transplant life, but the reality of life is important. Why pharmacy surgeon partnership is not optional, and patients letting us know exactly what's happening. For any transplant patient listening who wants to check whether a specific food is safe with the immunosuppressant or even supplement, MediMealSafe app does that in real time. You enter your medication, you search the food or supplement, and you get an instant answer. It's a pharma plan systems, and the link will be in the show notes. So, Dr. Dolamu, we're going to talk about what to embrace because nutrition after transplant is not only about restriction. It is about actively using food to protect your new organ. What does the ideal diet look like for someone who has just received a kidney or pancreas transplant? What changes and what surprises patient most?
So I'll try my best to answer. Medicine is so specialized these days that we have specialists for almost everything. We have a pharmacist that handles the medication part, so we're really spoiled. We have dietitians that help with the dietary part. But one of the benefits of kidney or pancreas transplant is that patients get to normal, almost normal, and that's normal in quotes. So for majority of our patients, the restriction they had before, a lot of it, which like that they should reduce high phosphate diet like cheese, yogurt, that they need to stay away from them. Potassium diet, like with end-stage kidney disease or patients on dialysis. Most of those things go away, especially the high phosphate diet part. Right after transplant, we actually encourage them to take a lot of high phosphate diet, things like cheese, yogurt. And the reason for that is that the body has been starved of those nutrients for years. And the bone especially is very hungry for phosphate right after transplant. So we strongly encourage them, and they can get dangerously low phosphate. Same with magnesium. So we prescribe a lot of those early after transplant. Potassium, yes, we tell them to eat normal diet, or someone that loved banana years ago. It's not that you should eat excessive amount of it. I generally advise them just eat like everybody else in your house that's eating healthy. I never used to put the word healthy there, but now I say that eating healthy. People that you live with that are eating healthy. So just normal regular diets. Don't indulge in excessive amount of banana or anything, because with tacrolimus, one of the medications, it can encourage retention of potassium. So especially at the beginning, before the kidney is fully recovered, we may advise you, okay, don't take too much potassium rich diet until the kidney settles down, or we get your tacrolimus level to an appropriate level. But just that's one of the advantages of transplant, just the ability to eat normally like everybody else.
Yeah. Yeah. Living a normal life.
Right. And for some of the pancreas patients, apart from the phosphate, magnesium, and potassium that I mentioned, because they have some pancreatitis at the beginning that can lower their albumin, they suffer with low blood pressure. So we generally advise them to include salt in their diet at the early part of the transplant, usually in the first 3 months, and also to eat diet that's rich in protein, because their protein will help increase the protein in their system, increase the albumin, which will help them to sustain high blood pressure. So we encourage our patients to include salt in their diet, as mentioned, but something else that helps to sustain their blood pressure is protein and albumin. So we encourage them to take diets that's rich in protein, and that will help them hold their blood pressure too. So those are things that are very important diet-wise that we advise our patients early after transplant.
Okay, good. So ongoing research into something that surprises a lot of people, and that's weight gain after pancreas transplant. So if a patient gets a new pancreas, diabetes resolves, and then they get weight. So tell us about that research and why it matters.
So that's something that I noticed and I was surprised about, actually, with pancreas transplant. So that patient that I mentioned earlier on, that I said was brought to clinic the first time she came to be evaluated for transplant by a 5-year-old daughter. Down the line, before transplant, her BMI was around 25. 3 years after transplant, her BMI was about 36. So weight gain after pancreas transplant is not uncommon. When we actually did our study and looked back at our patients, 80% of them gained significant weight. Most of the weight gain occurred between the first and the second year, where about 65% of them had gained weight, and about by third year, about 76.4% of them had gained significant amount of weight. And so that's one of the reasons we get our dietitians very involved with them. Back to nutrition, we hook our patients up early with our dietitian so that they work with them on the fact that you can now eat normally like everybody. And that's why I changed what I use. I say before, I used to say eat like everybody else at home, because you're now normal. You have a new kidney, you have the pancreas, you're like everybody else. But what we don't put into consideration is, how does everybody else eat? So I now say eat healthy. And so we get them connected with a dietitian, which share the literature with them that you need to eat healthy and you need to exercise, because there are patients that lose the organ, especially the pancreas. Not that the pancreas does not work again, it continues to work, because we're able to measure, there are things we measure in the blood that helps us to check whether the pancreas is working or not. That's the C-peptide. So we know the pancreas is working, but they can become diabetic. Rather, they go from being type 1 or insulin-dependent diabetic to type 2 diabetics. So that's why the nutrition after transplant is very, very important, and exercise, so that one does not gain too much weight.
Too much weight. Yeah. Okay. Well, very practical. Makes more sense. I like the fact that you you started saying healthy because you don't know what the person in the house is eating. That is definitely not good for them. So most people think that the guidance we give often sounds very Western. Sometimes it could be maybe brown rice, steamed broccoli, and that may not speak to the kitchens of some of our listeners. So whether you are a Nigerian family, you're cooking egusi soup and rice, a Jamaican household cooking stew and dumplings, or even a South Asian family eating dal and roti, or British family cooking ronderos. The principles of, I think, post-transplant nutrition apply, like you said.
Right.
High quality protein for healing, consistent potassium management, sodium awareness for blood pressure, and hydration. I know we didn't talk about that, but we talked about it before we came on the show. Hydration for kidney function. The goal is not to erase your culture or your food. It is to understand which parts of it support your new organ and which part needs adjusting. So I do they have a product called MediMeal Plan. It's meant to help you personalize a meal plan through that accounts for your medications, your health conditions, and your cuisine and your culture. So you could either be Nigerian, you could be Caribbean, Mediterranean, American, South Asians. It builds around what you actually eat. And obviously the link will be in the show at farmerplansystems.com. So, Dolamu, I do want you, if you have one, to share a story about a patient whose nutrition choices made a real difference in long-term graft survival.
There are several, especially with a pancreas patient. At the beginning, as I mentioned, we try to encourage patients um, to include salt in their diet because a lot of them are not used to taking salt because of the kidney failure. Some of them have been diabetic for some of them have been on dialysis for 5, 7 years. Some of them have been diabetic for years. So after transplant, despite the fact that people gain weight, it's a difficult transition from you can't take cheese, yogurt, beans, and all those things for years to transition to eating healthy. However, I remember patients that are used to eating. The patient I mentioned about fasting earlier on was the first patient that came to my mind, just intermittent fasting, which is not good for a transplant. Other cases that we've seen are patients that uh, before, I mentioned that most of the weight gain after pancreas transplant occurs between 1 and 2 years. I've had patients where um, just they eat. I don't want to mention McDonald's, but that's usually the corporate that
Fast
we
food.
mention. So, but there's a lot of fast food. So I've had patients that eat fast food and did not know the effect of fast food generally. So a particular patient comes to mind that was eating a lot of fast food, thinking it was the same or similar to what you ate at home. And then I connected that patient to our dietitian. And with the help of our dietitian, was able to work with the dietitian on exercise and also the type of food that you can eat to maintain a healthy caloric intake on a daily basis. So I think that has helped some of those patients. And the patient actually was able to lose weight. And there's some medications that people are beginning to use now, like the GLP-1s, that is beginning to help to, especially when we notice that they're beginning to gain weight. But generally, you don't want to use medication unless it's absolutely necessary. So that's why we got dietitians involved to help these patients, counsel them and advise them on what to eat, and so that they don't gain excessive weight.
That's the power of healthy food as medicine and not a supplement, not a prescription. I think a daily decision at the kitchen table with the help of a dietitian sometimes um, helps a patient take care of their health and still live a healthy life. The heart of this episode's legacy, I think it's the Nigerian conversation. I think what you do for people in Nigeria. And I'm going to zoom out and talk more about it. Something that I think is essential. And I think your position, before we go to the Nigerian bit, your position at OPTN, gives you a unique platform to address Black patients in United States wait longer for organs, they're less likely to be referred for transplant evaluation and they have worse outcomes on the wait list. So, what is driving this? And from your position, what is actually being done about it?
Thank you. That's a good question. Blacks generally, not just Nigerians, have it's have late referral for transplant, and it's because of a myth that existed and still exists in some quarters. How it started, I do not, that blacks do not benefit from transplant. So because of that, there are several providers that did not refer blacks or African Americans for transplant. And then I think on the other part of it, some of the immigrants or immigrants are reluctant to reach out to transplant programs and be evaluated for transplant. But on the other side, we will look at it. Some of it might have to do with, would my insurance cover this? Would I be joining transplant on a level playing field? But I tell you, irrespective of the color, say most transplant providers are like me. They like to see their patients do well. It's a thing of pride for every program to say, we transplant a lot of patients. We have 98%, 100% graft survival. So it might sound selfish, but we benefit from it a lot too, seeing our patients do well. And I'm sure it's the same for you. So whether the person is African American, recent immigrant, they should reach out to a transplant program, or even if their provider, their primary care nephrologist does not bring it up, they should mention it. One of the places where we're slightly different from Caucasian or people that have been here for a while is that we tend to defer a lot to religion and God and not advocate for ourselves. So we need to be a voice for ourselves. That we don't see that often. And it doesn't have to do with socioeconomic class, especially people that you see from Nigeria. It doesn't have to do with wealth. It doesn't have to do with even with literacy. I say that because I know even my dad will go to a doctor and you say, "Oh, so what did he say? What did he tell you?" "Oh, he put a stethoscope on my chest. They gave me fluid." "What did he say the diagnosis was?" So we tend to defy a lot. There are good sides of it, but we don't advocate for ourselves the health literacy. And that's one of the things I like about what you're doing, and thank you for doing it. The health literacy amongst Nigerians, immigrants, is probably lower than, or it may not even be literacy, but interest, just being willing to participate in our care. And the modern healthcare delivery system is one of partnership between the provider and the patient. So we really want everyone to be involved and engaged. And that's what I will advocate. So I'm glad you brought it up. It's an old myth that blacks did not benefit from transplant. That's not very common now. From the OPTN, we've done a lot of work to actually help a lot of minority that had referred late for transplant. One of the work we did that I was a part of was the use of estimated GFR, for example. I think up to about 4 or 5 years ago, if you look at the calculation for GFR, which is the glomerular filtration rate, which is the threshold that a patient can be referred for transplant, it has to get to 20% before you can start accumulating waiting time on transplant. The way the calculation was designed in the 50s had a black coefficient, whereby if a Caucasian has a percentage of 20% at the same creatinine, the same kidney function, and they could start accumulating waiting time for transplant. For a black, that could be about 22 or 23%, just by putting there that you are a black. So we've worked on that, and that's been changed. One of the things that was done is that if any black can go on the waiting list, can go back and say, look, I had a GFR that was calculated using the race coefficient 7 years ago, even 15 years ago, and I would have been listed back then for transplant. Their time on the waiting list will be backdated to that time. So there are a lot of changes that were made over the past 5, 7 years. So there's been a lot of improvement. The myth about blacks not benefiting from transplant, I think, has reduced. The disadvantage in the system. Those are the systemic racism. The system is being actively worked on, and I think the OPTN has done a lot of work over the past few years to modify those things and put in something that works for everyone. But what I think we need to do is just really educating people and getting people more involved in their care, which we don't see. I think it's still a disadvantage. We don't participate that much in our care. People go to the doctor. That's what my dad does. He puts a stethoscope on me. You're not really engaged in what's going on. So we like it when patients come in with a lot of questions. They want to know what's going on. They've read up about it to an extent, and we can then partner in their care rather than tell them what to do. So that's what I would say.
I am so happy you mentioned it. I'm grateful for what OPTN is doing. And the funny thing is, the first episode after mine was advocacy in pharmacy for people to advocate. So when you said that word, it resonated a lot. We have to advocate for ourselves. We have to partner with doctors because it's a partnership in your health. It's the same thing. One of the guests I had, a chronic disease doctor, mentioned that it's a partnership because it's about you and you have to own your health. Yes, the doctor has his role and we have our role as patients, and together one can move your health forward to where it's meant to be. So I'm glad there's much more than, and I hope our listeners can hear that is African Americans, blacks have advantages too. We're not just sidelined, and don't think that you are not eligible to be on a transplant. Ask your doctors. When you go into doctors' offices, ask these questions, write these questions down if you're not sure what to ask your doctor. And it. So what can people in the diaspora, Nigerian listeners, African listeners, anyone who has family back home, what can they do to support people with transplant patients?
I think there's a lot we can do. I think we can work. There are people that are making efforts to make transplant grow in Nigeria. I'll give you an example. Most of the transplants in Nigeria currently are done by doctors that are flying from India every other week. So I think something nice that we can do is to maybe go back and try and train some of the doctors there. Train the surgeons now to do transplant. I think that will help to significantly reduce the cost of transplant because these foreign experts that are coming to do transplant in Nigeria are paid in dollars per patient with their flight and accommodation covered. That's expensive. So that's something we can do on bigger scale. And also on a broader scale is try to be engaged. So I've tried to be engaged. I've worked with the Transplant Association of Nigeria because I have some policy experience on how to formulation of policy. Actually, there was a recent transplant guideline that was published last year that I worked with them on. So I think being engaged at the policy level, at training level is very important. But on an individual patient level, what I try to do with those and I know there is when someone is sick, if I know a transplant patient, I try to educate them. Talk to them about compliance, importance of taking their medication. I try to serve the role of the nephrologist, pharmacist, dietitian, and all those things. So there are many levels at which we can be engaged, but I think the one that will help the most, it's actually more at a systems level where people can be trained, surgeons can be trained to do transplants and try to achieve what we have here at a policy level, and hopefully some of us can get to the level or get access to decision makers in Nigeria, the Ministry of Health, the politicians, where they can see importance in transplant, in dialysis care.
Yeah, quite important. And if one can get to that point, the costs can be significantly reduced for even the patients. And so what would you tell patients who feel overwhelmed by this journey? they're overwhelmed by the transplant journey, by the medications, the food restrictions, the lifelong monitoring. How do you help them see this as a path forward rather than a life sentence?
So, there's something I say to patients: if you compare it with dialysis, so when someone has kidney failure, I'll use kidney as an example. When someone has kidney failure, it's like drowning. And they see they are drowning in reality. The kidney is not able to get rid of the waste. It's not able to get rid of the fluid. They have excess fluid in their lungs, so they cannot breathe. They have excess fluid in their legs and all over their body, in their heart, leading to congestive cardiac failure. What transplant does is to bring them out of the water onto the shores and actually far inland, that it takes a tsunami for them to drown again or dead. So is transplant perfect? No, it's not. But like I say, it's a journey. It takes a village to take care of a child in that journey. What I would say is just be reassured that you have a team. That village is there for you. You have your nephrologist, you have surgeon, you have the pharmacist, you have dietitian, you have several nurses, just like there are nurses that are pre-coordinators to guide you and hold your hands, educate you while you're on the waiting list. Because management of the waiting list is a process on its own. In our program, I think we have 6 coordinators, 6 nurses that manage the patient on the waiting list. After transplant, there's another set of 6 nurses that look after them. They're dedicated coordinator that they can reach out to 247 if they have any concerns. Their nephrologists are there, the surgeons are there. There's no point that they are left on their own. So we're there to support them. And so I don't think they should be scared. It's a lot. It can be overwhelming, but we're there to support them.
I think the takeaway from you, the most important thing is that you have a village and everybody's there to help you. Everybody is here to support you. And I think it's exactly the message transplant patients need to hear. This is not fair. But you have those people that are there basically for you. There's no restriction or direction. Excuse me. And for any transplant patient or caregiver who needs a guide, a complete guide to food that interacts with immunosuppressants or any other medication you're taking. My book, Foods That Clash with Your Prescription, covers tacrolimus, mycophenolate, prednisone, steroids, and any interaction every transplant patient needs to know in plain language, written for real people. And it's going to be in the link show at pharmaplansystems.com. So, Dolamu, we're at this point where we have something called rapid fire. So the quick questions, your gut reactions, you just answer. And are you ready?
Yes, as ready as can be.
Okay. So first question. One food transplant patients should never touch again. One food transplant patient should never touch again.
First thing, I'll say marijuana, if you consider it food. It's it's detrimental to general well-being, I think, and also the different formulations. Some patients can contract fungal infection from it. So I'll strongly advise transplant patients to stay away from marijuana if they can.
Question 2. The biggest post-transplant medication mistake you see again and again?
Years after transplant, patients being complacent and not taking their medications. It's very, very important to take it to prevent rejection and losing the graft.
Is it overrated, danger, or legitimate clinical threat?
I would personally avoid grapefruit if I was a transplant patient because it just causes too much interaction.
Best way to prevent an organ rejection in one sentence.
Take your medications religiously.
Okay.
All
One
goes back to
thing,
medication.
yeah. One thing you wish every transplant patient knew before surgery.
That transplant is beyond surgery. You need to get on the list and you need to take care of the transplant. It's a journey. It's like having a child. It goes from pregnancy to the actual child, and you have to take care of the child.
Yes. Okay. So one food you wish more transplant patients would eat more of. So next question, coffee or tea? And does Tacrolimus have an opinion on coffee or tea?
No, not directly in terms of interaction, but if I had to choose, I'm a tea person, so I'll say tea. But the caffeine and the diuresis that goes with both of them was with coffee. I generally advise my patients not to indulge in either coffee or tea, but if you have to take one, tea is better. But generally, just hydrate yourself with water or water with electrolytes.
I learned something. Okay, so if you could go back and tell your secondary school self one thing, what would it be?
Listen to your parents, because despite not wanting to study medicine, I'm glad at the end of the day that I did, and it's been very gratifying for me.
Very nice. Very, very, very nice. Finish this sentence. A successful transplant is not just about the surgery, it is about
The journey. So it's not about the surgery. Also, it's about the patient. So it's not just the surgery. It's about what does the patient want out of it. Just making sure the patient is happy, that the patient's expectations are met. And because especially when you look on the liver side, some of the liver patients, all they want is, I remember a particular patient that the son was getting married maybe about 6 months before her liver failed. And that's all she just wanted to make it to the son or the daughter's wedding. And had the liver transplant, did well. I think she's still alive. So little things like that. So a lot of things in life, we think as providers, we try to think of patients in terms of us, whereas what really matters is the patient. So as much as we benefit from it, but it's about what the patient's expectations are. And transplant is not for every patient. There are some patients that do well on dialysis, and dialysis is probably better for them. So I think it's about the patient at the end of the day. It's a partnership.
Johnny Bit. I like that, the partnership. I'm probably going to put down on every transplant show note we ever write. Okay, so we are going to close out. And before we go, if there's one message you want transplant patients and the families who love them to carry from this conversation, what would that be?
I would like to say that although the transplant seems overwhelming, it can be scary. Every patient that I've asked before surgery, they are very anxious. What I would like them to know is that we care, we're there for them, and we'll do our best to get them through it. And just like I've mentioned over and over, yes, it's about them, but we benefit from it too, because it's very gratifying for us. We are custodian of the organs. So we are grateful to the donor family. Partly because of that, we have a lot of interest in whoever receives the organ doing well. So we're there to support them. We're there to make sure they do well, and they should trust us with the process and partner with us.
That's beautiful. That you're custodians of the organ, and as much as they get something back, you as healthcare professionals too are getting something back. So, Adelam, I knew you were going to be great. I just didn't know how great. So, what you have built here at Rush, what you did back in Nigeria, what you're doing for your patients who some would never even get to meet you. It's the kind of work that makes this entire profession really what is. And here's what I want every listener to carry from today. The surgery is the beginning, not the end. The real work happens every single day in your medications, the medications you take, the foods you choose, and the life you commit to. Your your immunosuppressant medications are non-negotiable. If you're struggling with cost or with side effects or with remembering, talk with your pharmacist. We're here for that exactly. Talk to your support team, your doctors, your surgeon, your nurses, your dietitian, and food is part of your treatment plan. Sometimes grapefruit, pomegranates, St. John's wort, high potassium food. Just know your list. Share with your family. Make it part of your daily routine.
Well, I'm easy to find. I'm a transplant surgeon at Rush. So if you go online and put my name there, Dolamu Olaitan or Dolamu Olaitan, you'll be able to find me. I work at Rush University Medical Center. So if you look at the transplant surgeons here, you'll be able to find me here. And of course, we'll be happy to look after you, irrespective of where you are from in the world.
Thank you. Thank you so much, Dr. Olaitan. So we have different tools for transplant patients and caregivers. We mentioned the MediMeal Save app, which checks any food against your immunosuppressants in real time, including tacrolimus and mycophenolate. The book helps food that clash with your prescription. It covers the interactions transplant patients need to know in plain language, and the MediMeal plan builds a personalized eating plan around your medications and cuisine. So all that with Dr. Olaitan's link will be in the show notes. So we'll put all of those details, Rush University's transplant program, in the show notes also, if somebody is willing to read about it at pharmaplansystem.com/podcast. To everyone listening, whether you're waiting for transplant, if you're living with one, if you're caring for someone who is, or you're simply trying to understand what this journey looks like, thank you. Thank you for being here. Thank you for paying attention. And if this episode helped you, share it with a transplant patient who needed to hear this, with a caregiver who manages the medications, with a family member who did not know about grapefruit. It could make a difference. Subscribe on Apple Podcasts, Spotify, or YouTube so you never miss an episode of When Food Meets Medicine. So eat smart. Your body will love you for it. Until next time, thank you.
Thank you.